Good morning, everyone. Today I'll be presenting my paper on polymerase chain reaction for Mycobacterium tuberculosis genome in granulomatous anterior uveitis, analyzing 51 eyes. Granulomatous anterior uveitis is a common uveitic entity in India which can be due to tuberculosis, sarcoidosis, and other systemic or immunological causes. Laboratory tests like MON2, quantiferon TB gold, HRCT chest, serum angiotensin converting enzyme, etc. can have been used to distinguish between sarcoid, tubercular, and other etiologies. Polymerase chain reaction in the last 2 decades has become an important diagnostic tool and can detect Mycobacterium TB DNA from the intraocular fluid. However, utility of this test in granulomatous anterior uveitis in Indian scenario has not been evaluated yet. We aimed at determining the utility of PCR of Mycobacterium tuberculosis in establishing the diagnosis of tubercular anterior uveitis and to correlate the results of PCR with that of other tests like HRCT chest, TB gold test, and MON2 test. Ours was a retrospective cohort study which analyzed 51 eyes of 38 patients who presented with granulomatous anterior uveitis to us, and we did PCR for MTB genome 1, AIOC2024 and MPB64 in those patients between January 2016 and December 2022. We included the patients who presented to us with clinical features like mutton fat KPs, iris nodules, broad posterior synecdoche, and excluded all the other non-granulomatous uveitic entities. Statistical analysis was performed using Microsoft Excel and SPSS statistics tool. These were our parameters. Coming to the results, most of our patients fall in the age group of 30 to 40 years with a mean age of 43.21 plus minus 18.63 patients, with most of the patients being female. We had found mutton fat KPs in 60.5%, broad PS in 73.7%, and iris nodules in 50.8% of our patients. We performed PCR and we found that 63.2% patients showed a positive PCR results, out of which a combination of IS6110 and MPB64 genome showed the highest positivity, that is 65.2%, and this underlined the fact that if we include these two genomes, in literature also it is there that it increases the chances of positivity of PCR. Here is the agarose gel electrophotogram showing the PCR results in one of our patients. Here it shows that how it was positive for both MPB64 and IS6110. We also did real-time quantitative PCR in this patient and found 26023 copies per ml of MTB DNA. Coming to the correlation between the tests, we found that in 4 of the patients who had negative MON2 test, PCR was found to be positive, and in 3 patients who had positive MON2, PCR was negative in those, and it was statistically significant. And PCR and HRCT results also showed weakly positive correlation. However, it was not statistically significant, and PCR and quantiferon TB gold also showed a significant correlation between these two. So we treated the patients with ATT, and most of the patients responded to ATT and topical as well as oral steroids with and without immunomodulators. These are one of our patients showing positive PCR post and pre and post treatment. And we also found excellent results in 66.7% of our patients. To conclude, we can say that PCR for MTB genome is a valuable tool in diagnosis of tubercular anterior uveitis. PCR can be positive even in cases of negative MON2, quantiferon TB gold test, and HRCT in granulomatous anterior uveitis. A positive PCR can help us clinch the diagnosis of TB uveitis at an early stage and guide us in starting specific treatment, that is ATT. However, in our study, we saw that a negative PCR of aqueous aspirates doesn't always rule out the chances of tuberculosis etiology. But we are fortunate to have a lab in which we rule out most of the false positive results, as we have got a negative control, and also we have got a negative and a positive, false positive, and a false negative control also. So we are fortunate in that and in that aspect. But when we generalize, we can say that negative PCR aqueous aspirate doesn't always rule out the chances of tuberculosis etiology in anterior granulomatous uveitis, and however, it can help us a lot in those presenting with the clinical features we mentioned in this scenario, in Indian scenario, which is known to be endemic for TB. Thank you.
So did you have a control group wherein you diagnosed the patient to have a granulomatous anterior uveitis, you started the patient on steroids and they did not respond? As in, what would be the utility caseload-wise? Did you have a control group like that?
Sir, actually, in all our patients that were subjected to PCR, we were having a positive control as well as a negative control for all the patients. Fortunately, we have a dedicated PCR lab for the same. So for every patient we send for PCR, we have a positive as well as a false positive as well as positive as well as a negative control for PCR. So thus we could rule out those cases as well.
My point is about the practicality and the utility of adding a big test like PCR in the routine diagnosis of a granulomatous anterior uveitis.
Yes,
so
sir.
what my point is that if we do not do a PCR and if we go for the standard treatment of an anterior uveitis in a case of MAN2 negative cases, so how does it impact the outcome of those cases? So do you have a control group like that?
Actually, we didn't have any control group, but that our studies about that only, that we saw that the utility of PCR, how the PCR is being important in those patients who had a negative Montauk result and a negative HRCT result. Still, it responded to anti-tuberculosis treatment based on the PCR results actually. So this is what our study is actually about, that we want to emphasize on the utility of that
No,
PCR.
but my question is that what was the rationale behind starting you had your rationale behind starting the ATT.
Yes, sir.
My point is that do you have a group wherein you have a standard diagnosis of a granulomatous anterior uveitis?
Sir, we had, sir, first of all, yes, sir. Yes, sir.
Let me complete my
Sure,
question.
sorry, sir.
So you have a granulomatous anterior. Your paper is fantastic. Don't worry about that. My question is that in a case of a granulomatous anterior uveitis where your routine tests that you usually order for are negative, and you start the patient on steroids and the patient doesn't respond, and then you go in for an ATT.
Yes, sir. So my rationale for this, our rationale was that first of all, we chose very specific patients who presented with us to our clinic with granulomatous anterior uveitis features with mutton fat KPs, anterior uveitis features, broad posterior synechiae, and iris nodules. So we ruled out two granulomatous etiologies. So first is tuberculosis, second is sarcoidosis. Some viral etiologies were there. These are the main infectious and non-infectious etiologies for granulomatous anterior uveitis. So first we ruled out sarcoidosis and TB and viral etiologies by doing first of all serum AC also we did, and we did Montauk, HRCT, and PCR for viruses also we did so. Like whenever we send for the patients for PCR, we also included viruses also because it is one of the etiologies for granulomatous uveitis. So these are so based on our clinical diagnosis as well as the results, we started on ATT. So if there was a strong clinical suspicion, and also we take chest physician opinion also for all our patients. So in collaboration with our clinical suspicion, the laboratory test, and the chest physician's opinion, we started our patients on ATT, and also the response in our patient again helped.
All right, let me reframe my question. There's a patient of granulomatous anterior uveitis. You have broad posterior synechiae. You have mutton fat KPs. You have everything that points towards a granulomatous etiology, and your ACE levels are false positive, and your MAN2 is negative. What would you still go for a PCR?
Yes, sir. Based on the clinical presentation, and since India being a TB endemic country,
India is a developing country and economically backward country with less of availability of PCR, and we are less fortunate. We're not as fortunate as your institution. So that was my entire point about inclusion of utility of PCR in the routine diagnosis of granulomatous anterior uveitis, just based on a MAN2 positivity, because it's that was my entire question.
I agree, sir. We had been fortunate that for our institute, it was more feasible because it was a referral center and everything else has been tried. So that can be one of the limiting factors in our study. But yeah, we need to do.
Only after
Yeah.
everything else has been tried. You said it yourself.
No, not in every case, because but yeah, some cases uh, they were diagnosed as granulomatous, but they were not responding to only oral steroids and IMT. So we did go a step ahead and did PCR. But yeah, I agree that this study needs to be done on a broader level to like establish the fact that PCR is actually very helpful in granulomatous anterior uveitis as well. And there is one study, that CORD study. They have also mentioned about the various that how based on that how previous
it sure is helpful. PCR
Yeah,
of
yeah,
course
definitely,
is helpful.
definitely.
You I'm not saying it's not helpful. All I'm saying is, what is the practicality of inclusion of this test?
Yeah,
And what is
like
the
being a costly
versus
test.
comparing it to its feasibility? What is the practicality of including this test?
Yes, sir, I agree. Like we can include this test based on practicality. We can include this test only when all the other tests are negative and we have a strong suspicion of ocular TB. And since we don't have any other cheaper options, unfortunately, so in those cases we can go for PCR. For being, if we want to be selective, we can go for those patients who are having a negative Montauk, a negative QTB, a negative HRCT, but still the ocular picture is very suggestive of ocular TB. Then in those patients, and considering the
I think
in my head, I think if I would have been you, I would have gone for a PCR in cases which are not responding to a normal treatment.
Yes, sir, that is what. In those cases, first, definitely we'll try to do like oral steroids, and we will try giving. And if they are not responding, because sarcoidosis also can have like a similar presentation, definitely, as I mentioned before. But yeah, after ruling out everything, this can be our go-to step, next step. Thank you, sir.
okay. So I think that you should order that PCR for MTB only when the patients are not responding to the treatment or your patient is getting worsened, and you yourself has landed into the trouble by quoting that COTS 1 and COTS 2. Those are totally different things, and I think you should go ahead. Okay, so we will call the next one because we're not having so much time. We will
Thank
discuss
you,
it
sir.
outside the that hall.
But you had a very, very nice paper, Dr.
Thank you so
Anshu
much,
Peta.
sir.